I am Durhane Wong-Rieger, and I am President and CEO of the Canadian Organization for Rare Disorders. And just to put a little context in, I'm also Chair of Rare Diseases International, which is our global alliance of patient organizations. And relevant to this discussion, I sit as co-chair of what is now the ERDIC RDI WHO-sponsored working group on global access to essential medicines for rare diseases. So just for, I think Linda mentioned for rare diseases are those that quite frankly affect very small numbers by their very definition, some of them fewer than 1 in 2,000, some of them fewer than 1 in a million. And as you might imagine, it's very hard to do research and to develop therapies for such a small population, not only because we don't actually know a lot about the diseases sometimes, but because it's also hard to do the clinical trials when you've got few patients and the patients may be spread around the world. In fact, that's why, with up to 7,000 rare diseases, there are approved therapies for only about 5% of those diseases. And this is actually a big step up from what it was a number of years ago. And the impact, though, on patients, of course, is severe. Many of these diseases are severe, they're progressive, they are life-threatening. About 2/3 of them affect children. About 50% of those children will not live to see their 5th birthday. Things really began to turn around in the 1980s when the US passed the Orphan Drug Act, and in 2000 when the European Union also passed orphan drug legislation to actually stimulate research and to bring these drugs to completion. So today we have about 600 or so approved therapies. The sad news is that actually these drugs don't get to very many rare disease patients. In developed countries like ours, US, only about 10% of the patients who could benefit from these therapies and are indicated for these therapies actually get access. Globally, less than 1%. And the biggest barrier is actually not cost, because in the essential medicines that we have been researching, some of them are older drugs, they're generic drugs, they're repurposed drugs. The problem is, in fact, the lack of a rare disease system. There's a lack of infrastructure that appropriately can diagnose, refer, and actually treat these patients. Even in Canada, which has one of the very best healthcare systems in the world, rare disease patients often get lost. It takes 5 to 7 years to get an accurate diagnosis. Many of these patients are not only misdiagnosed, but they're given the wrong treatments, which in some cases can actually make their disease much worse. And in many cases, they may not get to a specialist who knows there's a treatment available and then is not able to treat them, sometimes not in time to prevent disability or to actually even prevent death. So this is one of the biggest challenges we've got. As you can imagine, in Canada, we were thrilled in 2019 when the federal government, really after Dr. Hoskins announced the Pharmacare program at the same time, put forth a proposal and a commitment to set up a national rare disease drug strategy, committing $500 million a year. We in the court have been working feverishly for the last 2 years to actually host the consultations, bring the clinical community together, bring researchers together, engage the health policymakers, and certainly the industry to come up with what we will hope will be a consensus proposal on how to get these therapies to the right people in order to get them treated. The things we really want to call for is a bit of what Linda suggested, and that is we need to invest in infrastructure. Not use the monies to pay for drugs, but to use the monies to develop timely, accurate diagnosis, to be able to have trained clinicians to set up rare disease centers as they have around the world, but not in Canada, and to actually put in place a monitoring program so that when patients are prescribed these drugs, a lot of time with a lot of uncertainty in terms of how well they're going to work because they've only been tested on small numbers. And we need to make them available because we can prevent death or disability, but we need to have ongoing monitoring to be able to collect the information, evaluate the drugs in real time, and make adjustments in terms of how well they're working. We believe that a national strategy where all funders, all payers come together is essential because it will, in fact, allow for us to have what we've been talking about, and that is the ability to command certainly equity in terms of access, but also be able to negotiate for the very best prices. We are very committed to bringing in these therapies in a way to ensure that the right patients get the drugs, that we can monitor these and we can return that information, improve their quality of life through other kinds of supports, and also ensure that this is going to be an affordable, sustainable program. So thank you very much.